fiber layer clinical assessment. We all know glaucoma is an optic neuropathy with characteristic optic nerve damage and visual field loss. With the introduction of the ophthalmoscope by Helmholtz in 1851, ophthalmologists were able to visualize changes of the optic nerve head associated with glaucoma. The detection of optic disc and retinal nerve fiber layer damage and its change is actually the cornerstone of glaucoma management. Assessment of the retinal nerve fiber layer for localized and diffuse damage has been traditionally based on clinical examination with documentation of the change that is primarily qualitative. With the latest improvements in optical imaging instruments, objective and quantitative measurements of the retinal nerve fiber layer are now possible. At times, when pre-perimetric diagnosis of glaucoma is the goal, the search for subtle signs of damage in the nerve fiber layer is of utmost importance. They are especially helpful for early glaucoma diagnosis and in eyes, as Dr. Nangi has already pointed out, with small optic discs. The neuroretinal rim, we've been hearing so much about it, is actually the intrapapillary equivalent of the retinal nerve fiber layer. And qualitative and quantitative changes in this structure reflect the nerve fiber loss that occurs in glaucoma. Localized defects in the nerve fiber layer are the easiest to detect. They are very specific to differentiate early glaucoma from normal eyes. They occur in 10 to 20% of ocular hypertensive eyes and must be looked for in every glaucoma suspect. The high specificity is clinically useful in identifying patients with either impending or established perimetric loss. We can all see that this huge big defect here and this defect here is very easily visible on a slit lamp examination. Clinical examination of the optic nerve head and retinal nerve fiber layer is, however, subjective, qualitative and variably reproducible. What I might think to be a retinal nerve fiber layer might be easily missed by a novice. There is wide inter-observer and sometimes even intra-observer variability in between different examinations. Therefore, accurate and objective methods of detecting disc and retinal nerve fiber layer abnormalities and their progression would facilitate the diagnosis and monitoring of glaucomatous optic neuropathy. Let's go on to the qualitative examination. A qualitative examination can easily be done, as I said earlier, on stereoscopic optic nerve head photography, which is simple and low cost, and it is extremely useful because it allows a three-dimensional and a permanent recording of the optic nerve head appearance. It also allows us the interpretation of conventional photography. However, the interpretation of conventional photography remains very subjective. The current standard for evaluating the retinal nerve fiber loss during a dilated fundus examination consists of an inverted stereoscopic image obtained with the slit lamp biomicroscope and a handheld auxiliary lens. Commonly used lenses, like we all know, are biconvex, non-contact. They could be either 60, 78 or 90 diopters handheld lenses. A slightly improved view can actually be obtained through a contact type lens. This, however, entails a longer examination time, it's discomfort to the patient, and there can be some temporary clouding of the cornea which undermines the view of subsequent photography or imaging. While simple and accessible slit lamp biomicroscopy of the retinal nerve fiber layer is difficult to interpret, the data cannot be quantified. Localized wedge-shaped defects are usually seen in association with notching of the neuroretinal rim, a vertical enlargement of the disc, or following disc hemorrhages. We have heard all of this in the previous talks. In early glaucoma, bundle defects in the nerve fiber layer may not be associated with neuroretinal rim thinning because the initial damaged nerve fiber layer is located in the deep retinal layers. Now, if you look at all these pictures, you can see this shows very small defects, whereas if you look at this one here, you can see a very nice big defect. Focal wedge-shaped defects infrequently occur in glaucoma, however, they are easier to detect. In contrast, diffuse nerve fiber layer loss occurs more commonly, but it is very difficult to ascertain. A well-exposed fundus color photograph allows the retinal nerve fiber layer details to be better scrutinized than does any type of real-time fundus examination, even under the best conditions. For example, you could have the best lighting, magnification, and you could have the best lens that you would want to have. Now, these are just pictures. These are just pictures showing a huge loss here and a little loss here, and you can see these little spindle-shaped defects here. Many localized effects can be easily seen. Generalized loss can only be picked up on monochromatic photographs, and photographs depend on blue narrowband interference filter with a peak transmittance of 495 nm. If you look at this, there's actually a diffuse loss here which is difficult to pick up on just simple stereoscopic photography, but if you look at the vessels, that's what gives you actually the clue to a diffuse loss. As the RNFL is difficult to see through the camera, it is best to focus on the blood vessels about half a disc diameter away from the disc. Focusing on the deeper optic disc will put the retinal nerve fiber layer completely out of focus. Measuring the intraocular pressure with fluorescein before a fundus picture will also give you a grey picture with a poor contrast, as the fluorescein will also absorb some of the blue light. Intra-observer variations are around 15% in retinal nerve fiber layer assessment, though inter-observer variations are higher. Slit-like and localized defects are detected easily as they appear as dark areas outlined by intact retinal nerve fiber layer. However, there could be physiological slit-like appearances or spindle-shaped defects, but the physiological ones don't go right up to the optic disc. You just see small defects beyond the optic disc. Now if you look at this slit defect, you can see that this is going right up to the optic disc. If you look at this slit defect, it is going right up to the optic disc. So this is definitely a pathological slit defect. Evaluating the visibility of blood vessels is invaluable in identifying diffuse retinal nerve fiber layer damage. In defective areas, the vessels are covered only by the inner limiting layer, and so they stand out very sharply. In mild or moderate retinal nerve fiber layer loss, the first order vessels are bare with sharp margins, and complete loss of retinal nerve fiber layer pattern with clearly seen second order vessels suggests a diffuse atrophy. It's also useful to compare the superior and the inferior margins of the same eye. Comparison of the superior to the inferior margins is the best way to differentiate between media haze and early retinal nerve fiber layer loss. As the inferior rim is seen more clearly, a reversal of this pattern helps identify an inferior loss of the retinal nerve fiber layer. For instance, over here, you can see that the inferior notch is seen pretty clearly, and you can see the defect associated with it. So, also here, you can see that the inferior rim is lost, and you can see the inferior rim, the wedge loss quite clearly as compared to the superior, where you can actually see you can't see the striations, but you can see the superior disc margin pretty clearly. Stereoscopic photographs provide a hard copy snapshot of the retinal nerve fiber layer with improved resolution over a real-time slit-line examination. Small rigid pupils, media opacity, or a lightly pigmented fundus can drastically compromise the ability to look at the retinal nerve fiber layer details. Therefore, slight changes in the camera angle can introduce variability which limits the ability of this technique to a certain progression. Then what are the advantages of optic disc photography? It's very similar to a clinical exam, so you don't have to do anything different. A full color helps to distinguish between cupping and pallor. There's a better detection of disc hemorrhages. Many times you might miss disc hemorrhages on real-time fundus. It aids in the detection of the peripapillary atrophy. It's a stable technology, less expensive as compared to any other imaging devices. But there are disadvantages as well. It's qualitative and not quantitative. There could be a lot of inter-observer variability. High quality of photographs are required for accurate interpretation. May be difficult to detect subtle changes just with a photograph, and it requires a special handheld lens for viewing and interpreting both. Digital evaluation of the optic nerve has progressed over the last 30 years. Various techniques for analyzing photographs have been utilized to provide objective data from photography. Techniques such as stereophotogrammetry, stereochronometry, raster stereography were developed to analyze the optic nerve head and or disc photographs. However, often expensive and complicated, these techniques fail to reach the level of common use. In the 1990s, 3 new technologies were introduced for optic nerve imaging which garnered significant interest. These are, as you all know, confocal scanning laser ophthalmoscopy, optical coherence tomography, and scanning laser polarimetry. Now, what do you see from all the qualitative imaging? The HRT uses the principle of confocal scanning laser ophthalmoscopy, and the clinical parameters that are measured are the optic disc tomography. The GDX uses the scanning laser polarimetry, and you can see the retinal nerve fiber layer thickness. The OCT uses interferometry, and again helps you to see the retinal nerve fiber layer thickness. It's important to emphasize that a direct micron for micron retinal nerve fiber layer thickness comparison between histology and imaging is probably unachievable owing to both histological and imaging artifacts. Qualitative knowledge can be gained from a comparison of these fundamentally different approaches, such that the information collected using these approaches can serve to strengthen each other or question each other depending on how clustered the results are. Clinical correlation is thus an essence of good clinical practice. Thank you.